Okay, Aisha, just to say, I'm getting that message again that the host disabled
Yeah, I'm
attendees.
just putting that up. Sorry.
I'm not sure what that's about. Can everybody see that okay?
Yes, ma'am.
Yes.
Okay. So I will just keep going then to the next slide. So what I thought, and I hope this will be useful, I've put a few slides in on oral examination. Now, I will be honest with you, this is something that speech and language pathologists in the UK really struggle with. So I hope this will be useful as we go through this. So in terms of oral examination, why is it so important? Well, it's really, really important that we do observe the child before we actually start doing anything with them. It's really important that we look at them and start to get an impression of what that child is actually looking like. We want to rule out any structural abnormality that would actually inhibit or prevent the development of a complete phonetic inventory. We also want to do an oral exam because it gives us information on the movement of the articulators, and it really does form part of a comprehensive assessment for a cleft child. It's always good just to revise again of the anatomy inside the mouth. You can see there the hard palate and the soft palate. You can see the uvula, you can see the tonsils, and you can see the tongue there as well. And we always encourage our students to get very, very familiar with looking at normal anatomy. And obviously the inside of all of our mouths looks slightly different from everybody else's. So, you know, maybe that's a good exercise to do if you haven't done it already. Become very familiar with really looking at normal anatomy inside the mouth. The equipment that you need, we would always encourage our therapists to have a light, whether that's a pen torch or a light on a phone. I know we are very much in the COVID-19 era at the minute when oral assessment is going to be more challenging, but these are still the basic principles for being able to do it. Gloves, a tongue depressor, and a reflective surface like a small dental mirror. And I'll explain a bit more later on why we need to have that. In terms of a very, very basic checklist for an oral exam, we want to get an idea of the child's general facial appearance. Is there anything really jumping out at us whenever we look at that child's face? Is there anything that seems unusual? Is there anything that's asymmetric? Is there anything that would make us look at that child maybe twice because they just look a little bit different from maybe another child? We want to get an idea about the lips, about the tongue, about the teeth, about the hard palate, the soft palate, and the tonsils as well. We always want to be on the lookout for a submucous cleft palate. And you probably know what this is already, but just a reminder that it is a significant defect of the soft palate without the actual opening into the nasal cavity. And the indicators of a submucous cleft palate, the big one is that bifid uvula, or the groove, or if you align even in the uvula, the zona pellucida, which is that greyish, bluish color to the soft palate, and you get that because there is actually the cleft is underneath the tissue covering it. A notch into the hard palate, incorrectly positioned muscles, and another indicator that it could be a submucous cleft palate would be that the parent reports a history of feeding difficulties and nasal regurgitation. And I have some photographs here just to show you again. You can see the normal palate at the top, and then you can see the submucous cleft palate, and hopefully you can see that zona pellucida in the middle of the soft palate there, and also the bifid uvula. I've got a few other photographs here as well, which will hopefully you can see. Again, you can see in the top left the bifid uvula. in the top right as well, you can see the defect in the uvula. In the bottom right, you can see where there is possibly a bifid uvula there, but there's definitely a groove in the uvula. And again, in the bottom left, you can see that zona pellucida in the soft palate. So really, really important to be looking out for that in the oral exam. It is not uncommon that speech and language pathologists are the first to pick up a submucous cleft palate. And just 6 weeks ago, just before lockdown, I had a little boy referred to me in my clinic, and he's actually 6 years of age. And as soon as he walked in through my clinic door, I was suspecting that there was something wrong with his palate. And he has a submucous cleft palate that has never been picked up until now. And he's 6 with awful speech. So it does happen. And there's some other pictures of a submucous cleft. I really wanted you to see that one on the right hand side, because you can see there that notch at the posterior border of the hard palate. It's very obvious there. Sometimes it's easy to see it or feel it. It's sometimes easier to do that than at other times. But the bifid uvula and the zona pellucida are often the big giveaways for a submucous cleft. And you might look into somebody's mouth and actually see a cleft palate that has never been picked up before. I've included this one again with the fistula, just always to be aware. It's the same photograph that you saw before, of being aware if there is a fistula, a residual fistula in the palate. Occult submucous cleft palate, again, you maybe have heard of this. This is a defect in the muscular bulk on the upper layer of the soft palate. It's not usually detected by an oral exam, and really nasendoscopy would be needed to actually show the V-shaped palate from above. But again, you might suspect that there is something not right with the palate because of lack of progress in speech and language therapy, or because there are a lot of cleft speech characteristics that are persisting. And that would be a really good occasion when you would speak to, if you're able to, you would speak to a surgeon who you possibly work with or you have contact with, and ask them to look at the palate in more detail. And I know that's easier in some centres than others. Okay, any questions about oral exam before we move on to actually think about key questions to ask when evaluating articulation and resonance?
Any questions? Ma'am, it's clear.
Okay, well look, I'll keep going, and maybe what we could do is, if you have any questions, why not write them down? Because I'm just conscious, you know, we don't have a lot of time today. Aisha, I would be more than happy for students to write questions down, and you maybe feed them through to me later, or whatever way, whatever is of benefit to you at this time.
Thank you very much. That would be lovely. Sometimes it's when you see the slides again that you have questions. So if somebody does have questions later, we will definitely send them your way.
Okay, thank you. Okay, so some key questions to ask then when evaluating articulation and resonance. And I suppose the big question that we should always be asking is this child's articulation and resonance within normal limits or not? If it is, brilliant, we're not needed. If it's not within normal limits, then we need to be thinking, is the speech disorder related to the cleft? If it is related to the cleft, what are the factors that are contributing to that? And how can I effectively evaluate articulation and resonance for a child with a cleft palate? Now, I realise these are really big areas, and they're areas that, as speech and language pathologists working in this area, we spend an awful lot of time doing additional training to really become skilled in all of this. So really, this is just really, I suppose, introducing you to the key questions that we need to be asking. it's good to remind ourselves of velopharyngeal function, because this is going to be a really important thing to remember in all that we're doing in assessment, and whether the velopharyngeal function is adequate or inadequate. And you can see there I've provided you with a definition of velopharyngeal function, and the reminder that if it's deficient or inadequate, then there is dysfunction, or VPD. And I've just given you some diagrams there just to remind us of the normal velopharyngeal function for speech, where the soft palate makes that closure with the posterior pharyngeal wall during the production of oral consonants or vowels. I've just given you a reminder there of what needs to happen in normal velopharyngeal function, and you can take time to read through all of that later. It's good to remember that we all have different closure patterns, but generally, even though velopharyngeal closure will vary with different phonemes, the greatest pharyngeal closure is actually needed for the high pressure consonants. There are both cleft and non-cleft causes of velopharyngeal dysfunction. For us, the most common are those structural causes. So cleft palate, a short palate, maybe post-surgery insufficiency, a fistula, post-adenoidectomy. But there can be other causes of VPD as well, which are more mechanical, mislearning, or neurogenic. And maybe some of you have come across in the literature where some authors will talk about velopharyngeal insufficiency, or velopharyngeal inadequacy, or velopharyngeal incompetency. And those are all different terms that are used to actually track back to the cause of the VPD. But for the purposes of today, I'm just going to refer to VPD, velopharyngeal deficiency, as velopharyngeal dysfunction as a general umbrella term to describe the soft palate not making adequate closure with the posterior pharyngeal wall. It's good to remember as well that in terms of resonance, we're talking about hyperresonance and hyporesonance. And again, I've given you a definition there of what hypernasal resonance is. And it's basically too much air flowing through the nasal cavity during speech. Okay, it's a perceptual feature of VPD. It's most noticeable on vowels and approximants. And because the soft palate is not making that closure, there is too much nasal resonance during speech. Hyponasal resonance is basically the reduction of nasal resonance, and that's associated with nasal consonants. It impacts less for speech sound production because we don't have as many nasal consonants as we do have oral consonants. And hyponasal resonance is that perceptual feature that makes all of us sound as if we've got a very, very heavy head cold. But here's the big question that we all want to ask then: how do we rate it? And in terms of rating resonance, we can actually rate it in a very simple way or in a more complex way. So for example, we could basically just say in a very simple way, it's normal or it's abnormal. Or we could get into a little bit more detail, where we could say, yes, it's abnormal and it's hyper, or it's hypo, or it's mixed. We could go to another level again, where we could say, yes, it's abnormal and it's hyper, and it's either mild or moderate or severe. And then we can go to another level of complexity again, where we could bring in the consistency element, where we could be saying, yes, it's abnormal, it's hypernasal, it's moderately hypernasal, and it is consistent across all of the child's speech profile. So you can see that speech and language pathologists working in this area will rate it from simple to quite complex. But do you know what the first stage is? Is actually being able to determine, is resonance normal or abnormal? So that's really what I would be encouraging you to become proficient with first. Is it normal resonance or is it abnormal? In terms of hypernasality, here's
Sorry,
some good...
can I just ask you a question here? I think a lot of students would want to ask this question as well. So when you go back to abnormal versus normal, is that again just a very subjective thing? Is that a subjective term that you're using? So
Yes,
I consider...
Yes, very, very subjective. So, for example, we would be encouraging our speech and language pathology students to really think about that first of all. If they're listening to a child, ask themselves, does that child's resonance sound normal or abnormal? It's as a starting point. Because if it sounds normal, then you don't need to do any further assessment. If it sounds abnormal, then that's when you want to start actually doing that assessment to really look at it in more detail.
Thank you.
Does that make sense?
Yes, to me it does. I knew that some of the students wouldn't ask this question, but I wanted to ask it on their behalf.
Okay. And then in terms of, if you're asking yourself, can I hear hypernasality? And you're thinking, yes, I can hear hypernasality. Well, here are some good ways to actually listen for it a little bit more. Can I hear it on vowels? In counting, now obviously this is in English, but in counting 1 to 10, whenever you count from 2, 3, 4, 5, 6, okay? So the numbers between 2 and 6, there are no nasal consonants between 2 and 6. They're all oral consonants. So if you ask a child to count from 1 to 10, and whenever they're counting 2, 3, 4, 5, 6, you can really hear that they sound nasal, then you're thinking that they are hypernasal is probably correct, because those sounds 2 to 6 will really let you hear it if it is there. If they're counting between 2 and 6 and actually it sounds okay, then they're probably not hypernasal. Another sentence there, we were away all year. Again, there are no nasal consonants in that in that sentence. So if you ask a child to say that phrase and they're sounding hypernasal when they're saying it, then they probably are, because there are no nasal consonants in there to make it more difficult to hear it or to cloud your judgment. Another thing to ask is it affecting intraoral air pressure for consonant sound? So for example, if you ask a child to say maybe a word beginning with B and it actually sounds more like an M, or you're asking them to say a word beginning with D or copy the sound D, and it actually sounds like an N. That's a really good example of how the hypernasality is affecting the intraoral air pressure and is not allowing the child to make that oral sound. Another good thing to do is to check, if you hold the child's nose, is there a resonance shift? So say, for example, you've asked the child to say a word like daddy and it sounds like nanny, and then you hold their nose and you ask them to say it again and it actually it sounds like daddy. Well, then you know that by holding their nose, you have actually prevented that excess air coming down through their nose. You've actually enabled the child to produce the sound orally. But if you don't hold their nose, it will go back to sounding hypernasal again. Any questions about any of that?
Thank you.
Okay, in terms of rating hypernasality, and this is just really to give you
Sorry, can I just ask a question here? I'm so sorry, it was taking me longer to unmute myself.
you're
So
okay.
you know when you're asking the child to say daddy, and then
Yeah,
so you pinch the nose and the child goes daddy. So it's still daddy, but still pretty much in the nose. What happens in that case? So pinched the nose, but yet there is still that hypernasality. Well, not hypernasality, but there's still that nasality.
yeah. I suppose what the reason that we would suggest holding the nose would be if it's sounding very hypernasal when you're not holding the nose. And then when you hold the nose, does it improve it? Um, but it will, yeah, it will possibly still sound a little bit different, but you should hear that they're able to make a better attempt at the oral sound because you're holding their nose.
Right.
It's a really good way if the child is replacing an oral consonant with a nasal consonant, just by very quickly holding their nose, it's a very quick way of checking if it does help.
Thank you.
Okay, I'm just to say to all of you, I'm hoping to be able to share some videos um with Aisha, and hopefully that will maybe help to demonstrate some of this as well, and that might be of use to you. Um, in terms of just that final little bit on there that I have, the rating, the hypernasality, again, just in case you're looking at any of the literature, we use an audit protocol in the UK to actually rate hypernasality. It's called the CAPSA, that's the Cleft Audit Protocol for Speech, augmented, and that's used to actually really, I suppose, classify or rate hypernasality in a more complex way. It's really important that we are able to differentiate between hypernasality and hyponasality. It's good to remember that hypo is the reduction or absence of expected nasal resonance associated with nasal consonants and adjacent vowels. And the way to really make it to listen to for hyponasality is to listen to nasal sounds. So, for example, I've given you a few examples there, like my name is May, my mum makes jam. So sentences that are packed with nasal sounds. And if a child is saying that, and it actually sounds more like they're using the oral consonant B instead of the M, then that is a good indicator of hyponasality. So instead of my mum makes jam, it might sound like buy, bub, bake, bam, where they can't get that nasal sound because there's a blockage in the nasal cavity, and they can only then produce it in an oral way. So really important to be able to differentiate between hyper and hypo. And thankfully, and I'm going to be sharing this with Aisha, we do in the UK have a rapid assessment of resonance, which actually helps us to do that. And we have it on, I have it on the screen here, where, and again, obviously this is in English, but maybe you would be able to adapt it for the Pakistan context. But it basically gives you words that you can ask the child to say. It gives you some examples of what they might say, and if they do say that, what the outcome is. And you can see there, for example, if I go down to the second section, if you ask the child to say daddy, 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 and the child says nanny, 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 then the outcome of that would be hypernasality. You're confirming that the child is hypernasal. Now, this has been very much written for, for the UK context, because you can see there it says refer to the Cleft team. But I will share this with Aisha, and maybe this is something that you could use or adapt in the Pakistan context?
Thank you very much. This is something that I was speaking to you about earlier as well. That
Yes,
maybe this is something that we can look at as a future research project, and
yes,
have you supervise. And I think we have a lot of other projects coming up, and we're always looking for there are more students and less projects, and we have to make up
yes,
some projects. And I think this would be a really good project to have. And Rafia here works a lot with dysphagia, and she works a lot. So she teaches a lot of cleft palate related things as well, because she's teaching anatomy and physiology. And I've seen some of her lectures, and she has cleft palate. So I think it would be lovely if we could at some point just get together and maybe discuss opportunities for research within cleft lip and palate with you.
yes, 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 no problem.
Ma'am, basically we are going to make a screener for hypernasal TA, so maybe we can discuss it with you as well.
So Rosie, Rafia is in the process of developing a screener for hypernasality. And she was just saying that whether she could sort of liaise with you and see how it
Yes.
goes, discuss it with you.
Yes, no problem. My apologies. I thought she was talking to you, Aisha. I'm apologies that I didn't respond there. Yes, absolutely, no problem. I am more than happy, and I'm happy for you to pass on my email contact details as well, Aisha. There's no problem with that.
Thank you.
Okay. I mentioned as well about nasal airflow, and it's really important that we are listening and watching for nasal airflow as well. I've given you a definition there of what nasal airflow is, and in particular nasal emission, which can quite often accompany pressure consonant production. And this is usually associated with velopharyngeal dysfunction, and you can see the diagram there. You can see that because the soft palate is not closing, it allows for that nasal air emission through the nose. Nasal turbulence is also part of nasal airflow, but it's a more noisy nasal airflow because it's often associated with a smaller velopharyngeal gap. Sometimes we refer to it as nasal snort or nasal rustle as well, but it can be very, very distracting to people listening to the child. And in terms of how we assess that, and you've maybe seen this already, but this is where we tend to use the reflective surface or the dental mirror, where we actually ask the child to say some words or to repeat some sentences, and we put the dental mirror under their nose, and we watch for misting on that dental mirror to confirm our suspicion that there is nasal air emission whenever they are speaking. Sometimes you can hear it and you don't need to even do that, but sometimes it can be hard to hear, and this is another way of assessing for its presence. We also need to be aware of nasal and facial grimace, and that's a compensatory behaviour that sometimes the speaker can be doing without even being aware of it. It can be an indicator of velopharyngeal dysfunction, although it can also be part of mislearning. There are different degrees of grimace as well, but this is where it's really important that we're looking at the child. We don't have our heads down all the time trying to get the transcription absolutely right. We need to do that as well, but we also need to build time in to actually look at the child whenever they're speaking. Okay, getting on to cleft speech characteristics. And again, you'll be glad to know that I have resources that I'm going to be forwarding to Aisha to support this. In terms of what we do in the UK, we would use some centres would
Sorry, Rosie,
use...
just to let you know, we've got 10 minutes and then we'll come back again. We have some questions as well. Is it okay if I ask you those questions before we move on?
Yeah, sure.
If that's okay. So some of the students have actually sent messages. So Kainath has sent a message saying we tried candle for the production of oral consonants. He picked this concept quite faster than the air must come out of the oral cavity. Okay, so
Yeah.
Kainath is saying that we used a candle and we felt that he'd grasped the concept that the air must blow out of the oral cavity with a candle.
Yes, and we would do different activities and games with children to help them to really get the feel of air coming out through their oral cavity. We're actually not allowed to use candles with children in the UK now because of health and safety concerns. So that's the reason why we don't use them anymore. We used to use them and get children to, to blow out candles. Obviously, we were doing that just to let them get the feel of air coming out through the mouth. We all know that blowing exercises do not strengthen the palatal muscles in any way, and we should never ever use blowing or sucking exercises because we think that will maybe improve the velopharyngeal function. There is no evidence to underpin that, but blowing exercises can be useful to let the child feel oral airflow.
Before we go on to the next question, I do want to mention here that when I started, when I considered going to speech therapy,
Yes.
I went and observed a session somewhere. I was
Yes.
told, it's okay to maybe do the diploma in Pakistan or do a course in Pakistan. And I went and observed, and this was 2001, I think. I went and observed, and it is actually these candles that put me off that course, because I went and I saw candles and blowing, and it did not feel right. It did not feel right that you would have a candle near a 3-year or 4-year-old.
No.
So it was really concerning for me even then. And when I did go back to England, I studied. One of the first things that they, threw out of the window was the candle and the blowing and the sucking. So,
Yes.
so yes, but in Kainath's case, I can sort of understand what she's trying to say. So she's trying to say that it's more of a
Yes,
visual
absolutely.
feedback. So I understand where she's coming from, but like you said, it's with candles, it's still a very scary sort of an area. But yes, for us, where we maybe have limited resources, and that is probably something that gives the child a visual image of being able to blow. Maybe think of something else that you can blow, or maybe
So for example, I would use bubbles, I would use bits of tissue paper, I would use feathers, I would use any very light materials, but Aisha, you're absolutely right. I think the main thing that we've got to remember is why we're doing it. And we're doing it simply to let the child feel air coming out through their mouth. We are not doing it to improve velopharyngeal dysfunction. If there is velopharyngeal dysfunction, then that needs to be repaired with surgery. Blowing and sucking exercises will not fix a faulty palate.
True. Thank you so much, Kainath, for asking this question, for your feedback.
Absolutely, very good question.
There's another one by Rida, and she says, we use mirrors in clinic for assessment of hypernasality, but the small mirror in front of the nose, put the small mirror in front of the nose and ask patients to speak words that have oral consonants.
Yes. Yes, you can get the child to do sounds, or you can ask them to repeat words with oral consonants. I would really recommend a dental mirror for this. I think a bigger mirror is just too difficult, and the dental mirrors are very good because of the way they are made, because they are made to go into for a dentist to use inside somebody's mouth. The reflective surface is actually very, very good. So I would strongly recommend, if you can get hold of just a small dental mirror with that long handle, it works really, really well under the child's nose.
And somebody has just sent me a message saying, how close is close? So how close should you have your dental mirror to the nose?
Well, we would obviously before COVID, like at the minute in the UK, we are not seeing any children face to face at the minute. So it could all change. But I would have had the dental mirror just under the child's nostril on one side and then would have moved it to the other side.
So just in terms of like, if you're not seeing any children, I don't know how things are in Northern Ireland, but I knew from when I left England years and years ago that the waiting lists were really bad, and then I found out that the waiting lists had gone even, you know, worse, had gotten even worse. I'm just assuming if you're not seeing children, is that going to impact on your waiting lists again and on the number of children that you'll have to see once this is over?
Yes, it probably will. When I say we're not seeing children, we're not seeing children face to face. So we're doing an awful lot of remote work with children, but there's only so we're doing a lot of therapy by teleconference. But we are really only learning about that as we're going along because it's all very, very new. And we are anticipating that over the next few months we will be able to start to see children again face to face. But how close we will be able to get to a child, that's still all to be worked out. So it's very, very challenging times. And obviously, from a teleconference point of view, the teleconference platform has to be very, very good to do a cleft speech assessment, because you simply might not pick up everything that you would hear and see if the child was in front of you in a clinic.
True. So is it okay if we leave this and come back to it? Because there's 3 minutes left. So for the next one, we'll be able to log in. So I'm going to end this for everybody from here, and then we'll come back, same ID, same everything.
Okay.